So one of the most controversial debates is actually in the pre-hospital setting when comparing supraglottic airways to endotracheal tubes, because the gold standard in the literature is a cuffed endotracheal tube through the vocal cords. Supraglottics, they carry a perceived risk of aspiration, they might not ventilate as well, and this has been investigated a lot in the past couple of decades. So in 2018, there were two big studies published in JAMA. The first one was the PART trial by Wang, and that looked at out-of-hospital non-traumatic cardiac arrest, comparing endotracheal tube to a laryngeal tube, or the King. And they were wondering if one or the other improved outcome for survival at 72 hours. It was a pragmatic cluster randomized trial in 27 agencies over 2 years. It enrolled in total about 3,000 patients. So looking at the primary outcome, the SGA had higher survival than the endotracheal tube group at 18.3% versus 15.4%, with an adjusted absolute risk reduction of about 2.9%, and that was statistically significant. The number needed to treat with that was about 35. The Airways 2 trial by Banger compared very similar things. That looked at supraglottic airway, and that was with the iGel, comparing it to endotracheal tube and non-traumatic out-of-hospital cardiac arrest. That was a multi-center randomized trial with 4 different paramedic services in England, and it enrolled about 9,226 patients. The primary outcome was the modified Rankin scale at hospital discharge at 30 days. The primary outcome in the Airways 2 trial showed clinical equipoise between the two, with no benefit in survival with one or the other, although there was a significant difference in the rate of ROSC, or return of spontaneous circulation, in the supraglottic airway group. So the argument of these two trials is, I think it pushed, and there was a big paradigm shift towards going to supraglottic airway first, because in the pre-hospital setting, especially in the United States, when you've got paramedics intubating, the average paramedic can intubate maybe one or even never in an annual period, and it requires a lot of rigorous training and a lot of different things and quality improvement and quality assurance to make sure that we're doing it the correct way. A supraglottic, while maintaining airway management is important, is much easier and faster to place, especially for somebody that doesn't do it very frequently.
So Aaron, then when do you think intubation is warranted in the pre-hospital setting compared to a supraglottic airway?
I think there's a couple scenarios. I think for most scenarios, going supraglottic first in out-of-hospital cardiac arrest is the right thing to do. Mm-hmm. There are a couple scenarios where the patient's airway pressures might need to be higher, meaning when I'm providing ventilation either with a bag valve mask or a ventilator, depending on what we're doing, I need to overcome a higher airway pressure, like an asthmatic cardiac arrest or drowning, when there's a lot of secretions in the airway or a lot of pulmonary edema. There is generally a tendency to get higher airway pressures with a cuffed endotracheal tube. Although with a lot of these, especially with the AirQ, the King, and the ILMA, if you overinflate the cuff a little bit, you can really generate high pressures, even in a patient that requires such high pressures. That would be the times that I would think going with an endotracheal tube eventually is probably the next best step for this. Otherwise, if you've got a supraglottic in and it's ventilating well and you've got good end-tidal return and cardiac arrest, I think we'd leave it and you can focus on everything else.
So the evidence in the pre-hospital space is actually a lot more robust than the evidence in the emergency department. There really is not much out there, and I think it's because supraglottic airways are pretty underused in the emergency department. And this was actually shown by April et al. Recently when examining a big registry database of 19,000 patients. Out of those 19,000, a supraglottic was used just 56 times, which is actually less common than a cricothyrotomy was performed. Showing that basically, even in the most extreme airway scenarios, we're underusing these devices, and really we probably should be using them more. The other evidence that is out there is actually from our institution at Hennepin County, where we looked at 10 years of our airway data and tried to figure out how often we use them and how well they work. And so we intubate about 1,000 times a year, so over 10 years, it's about 10,000 intubations. We ended up using supraglottic airways about 200 times. 100 of those times, it was used actually as a rescue device. So meaning intubation wasn't going well, and we placed the supraglottic airway as a rescue, either to rescue oxygenate or perform rescue intubation. And in that scenario, when things were not going well, it actually performed successfully in oxygenation 93% of the time. And this is the device we use at Hennepin. It's ILMA Fast Track, which you can intubate through, but I've a feeling that all of these devices would have worked equally well for that oxygenation piece. And you can really rely on it for that rescue. We also used it 118 times over those 10 years as a primary device, meaning it was the first airway device that went into their mouth. And this performed oxygenation successfully 99% of the time. Really, this is just to summarize that when these devices are used, you can rely on them to successfully ventilate your patient, whether you're doing it as the first thing you're putting in for their intubation efforts or after rescue. So just know that you can count on it.
So you think, based on that NEAR database study that you described first, there were more surgical airways than supraglottics used. I think in pretty much any scenario, if you look and you can't, even with vastly abnormal anatomy, you can't see anything, I think it's reasonable to try a supraglottic before going straight to surgical airway, unless there's something completely obvious that necessitates surgical airway. But even abnormal anatomy and everything, these work really, really well.
Yeah, absolutely. I mean, unless there's a contraindication to its use, you should always try supraglottic on your way to perform a cricothyrotomy, even if you're doing it simultaneously. You might be putting in the supraglottic at the same time you're doing the surgical, and if it ends up you can ventilate, maybe you don't need the cric, or you could do a slower cric. So the fact that there are more crics and supraglottic placements, that really does show that it's just not in our thought process for these patients.